Coming up next on Primary Care, we're here in Charlotte, North Carolina for Healthy Churches 2020 National Conference to hear from experts from around the country, share information on how to make our congregations and communities healthier. Hello, and welcome to Primary Care. I'm your host, Dr. Lonnie Joe. At the third annual Healthy Churches 2020 conference held in Charlotte, North Carolina, Dr. Felicia Hill-Briggs, President-elect of the American Diabetes Association, was invited to speak on diabetes and how to better manage this disease.
If you're able to carry out those behaviors that are critical for self-management, then you do not have to suffer all of the complications that can come with the disease.
We're pleased to be joined by Dr. Felicia Hill-Briggs. In addition to being President-elect of the American Diabetes Association, Dr. Hill-Briggs is the Senior Director of Population Health, Research and Development at the Johns Hopkins University School of Medicine. Dr. Briggs, welcome to the show, and thank you for joining us.
Thank you. It's a pleasure to be here.
Thank you so much. Diabetes. Every time we see these slides presented at conferences of the United States, another state has turned red and diabetes is taking over. What are we doing wrong?
Well, the problem of diabetes is a huge one, and it's a multifactorial one. But what we do know as the common denominator is that obesity is largely driving our increased rates of diabetes in the United States. And as a result, we also know that there are some solutions that can help us curb the tide and hopefully stop this trend that we've been seeing.
And those solutions basically start where?
So one thing that has occurred in the last few years, but is now policy, is that we have a national diabetes prevention program through the Centers for Disease Control and Prevention, the CDC. And that National Diabetes Prevention Program originated with a large study that was carried out across the country to determine whether or not we could either prevent or delay the onset of diabetes by making lifestyle changes. And we found that yes, indeed, by changing lifestyle, specifically by altering nutrition patterns and physical activity in order to reach a weight loss goal of about 7% of one's original weight, people who are at high risk for getting type 2 diabetes, people who are in what we call a pre-diabetes state, can prevent diabetes altogether or delay the onset of the disease.
I'm kind of glad to see that term pre-diabetes come back. You know, we eliminated it for a while, not thinking that it was not important. Now we have brought it back and emphasized the importance of it. This has helped us continue to educate patients, especially patients at higher risk, like African Americans. And there are lots of reasons that African Americans wind up diabetic, but self-management seems to be key in terms of progress.
That's very true. And in reality, self-management is really the set of lifestyle behaviors that must change in order to help manage diabetes and keep blood sugar levels under control. And we know that it's not an easy process. It's hard for people. Whether it's testing blood sugar, taking medications, being able to alter their nutritional patterns and maintain healthy nutrition, getting regular physical activity, being mindful of balancing out what they're doing so that they don't end up with very high or very low blood sugars. All of this takes tremendous information on the part of the patient to know what to do and how to do it, but more importantly, learning how to integrate all of these new skills and behaviors into their everyday lives. And that's a challenge for people.
So patient education is a must in terms of helping people achieve targets and goals in diabetes. What can churches do? We're here at Healthy Churches 2020, wonderful presentation by yourself today. What can churches do specifically to help the individual parishioner in that congregation?
Well, right. So let me start with I think what patients need. They certainly need education, and part of the American Diabetes Standards of Care are that every person with diabetes should receive diabetes self-management training and education about what to do and how to do it in order to meet goals. But we know that knowledge is not enough. In addition to knowledge, they need the support needed in order to carry out these behavior changes and maintain them over a lifetime. And I think that the church has a role in both of those components. We know that African Americans have much less access to the formal diabetes self-management education that's really dictated by our practice guidelines. And so churches become a resource for people being able to get the actual information that they need, accurate information, and that support network that goes along with information in order to allow people to carry out self-management in the context of their real lives and their real needs and the real experiences they're having. Diabetes isn't the only thing in their lives, and so diabetes and its care has to fit in with all the other priorities going on. And that's where churches and having that support network are critical.
Tell us about the Deside self-management program that you developed. That is unique in itself. Help our audience understand that a little bit.
Okay. And so I'm a researcher, that's part of my role, and my work is focused on how do we identify the most critical information for people at the times that they need it for managing their diabetes, and how do we deliver it in a way that it's going to be relevant and usable. Not just useful, but usable. And so I've actually spent 10 years with funding from the National Institutes of Health, developing and testing the effectiveness of this program, Decide, which stands for Decision-Making Education for Choices in Diabetes Every Day. And we developed the Decide program to incorporate all of the current standards of care for diabetes self-management, education and support, as well as learnings that we have about how people change behaviors most effectively. As a clinical psychologist, I wanted to utilize what we do professionally, which is problem-solving training and problem-solving skill sets that we utilize in order to allow information to go from pure knowledge to that active, actual self-management. And so the Decide program is a structured program that takes people through the process.
This can apply to other areas of what we do in healthcare also. We've been very good for decades in identifying things, but not quite as good in what the next step should be, which gives us the kind of outcomes that we have now in a disease state like diabetes. So here's a program that actually churches, doctors' offices,
Absolutely.
any kind of other education venues in the community can use to improve outcomes.
That's right. And the outcomes we improve are across the board. A1C, blood pressure, cholesterol, the health behaviors themselves that we're targeting, and people's satisfaction and just general quality of life.
How are mid-level providers, not necessarily from the traditional sense of a mid-level provider, but when we talk about going into churches, for instance, there are all kinds of programs that exist in lots of churches that could use this kind of approach to help the parishioners control blood sugars. Are they part of this program in terms of the rollout and the actual implementation of things?
I'd say the Decide program, as well as the Diabetes Prevention Program, the National Diabetes Prevention Program, have training modules for people who will be doing programs, conducting groups, working as those resources within the churches to ensure people have access to the curricula for the programs. And so what we do is we train the people who will be delivering it, and we provide the support for their monitoring and evaluating the outcomes of the program, because for each church, for each practice, for each person who's working with the program, we want to make sure it's working effectively for them.
Should we be taking a more holistic approach to the treatment of diabetes, especially since you mentioned the social determinants of health? Zip code comes up on every list I've seen. Transportation comes up on every list that I've seen as a social determinant of health. Should we be taking some other avenues or considering some other avenues and trying to get to the same target or the same goal?
I would say so. So population health is a term that refers to, in effect, a social responsibility of healthcare systems for not just the people who walk through the door, but for the health of the communities around their practice sites. And so what we need is those partnerships between both healthcare systems and communities in order to affect change in the systems that underlie many of our health outcomes. And so you will see, for example, partnerships between medical practice sites and housing and urban development. I mean, one might say, what does that have to do with the healthcare system? Well, certainly when you think about conditions such as asthma, or if you think about conditions where you see that direct link between how a person lives, where they live, place, and health outcomes, it makes a lot of sense for the medical sites and the healthcare sites and the hospitals to have an interest in what's happening in the communities and residences of its people. We talk a lot about the built environment. Whether or not neighborhoods have places to walk, a safe place for people to do just everyday exercise and physical activity. Certainly things like jobs, education, all of these factors play a role in health outcomes. And so if we think that social responsibility type of concept that's behind population health, yes, there is a role, a holistic role for all of these systems within our country.
So the hospital or the healthcare system just can't become this holding tank for disease states and accidents and problems to show up. There has to be an extension of that entity into the life of the patient.
Yes.
To actually get the outcomes that we desire.
That's right.
This is an amazing decision that you've made to take on this challenge as president, soon to be, now president-elect of the American Diabetes Association. What do you see yourself achieving in that leadership role?
Yes. Well, the American Diabetes Association has been undergoing a strategic planning process. And the things that we've been talking about here today, I'm proud to say, have been a part of that strategic plan. We have a strategic imperative that really is around raising our voices as an advocacy organization, as healthcare providers, as researchers, as public health professionals, to come together and address issues of health disparities in diabetes. That's one of the more pressing issues right now for us in the world of diabetes. And so through diabetes prevention programming, through bringing our evidence-based best care and best practices to the people who need it the most, we believe we are going to see a difference.
Wonderful. Thank you so much for joining us, Felicia. This has certainly been a pleasure. We'll do this again.
Thank you.
My guest has been Dr. Felicia Hill-Briggs, the president-elect of the American Diabetes Association and senior director of the Population Health Research and Development at Johns Hopkins University School of Medicine. When we return, we'll be joined by oncologist Dr. Karen Winkfield for a discussion on one of the most feared and misunderstood diseases, cancer. We'll be right back.
Number 2 killer, it's cancer.
You listen when your body says, "I'm tired," or "I'm hungry." What if your body said something else might be wrong? Gynecologic cancers, cervical, ovarian, and uterine cancers have symptoms, so pay attention. If your body says something may be wrong, please listen. If it goes on for 2 weeks, see a doctor. It may be nothing, but find out, learn the symptoms, get the inside knowledge about gynecologic cancers.
Welcome back. Cancer takes the lives of more African Americans than any other racial and ethnic group in the United States. Barriers to access to health care, lack of cancer screenings, and lack of minority participation in clinical trials contribute to the higher number of deaths. Joining me to talk about the toll cancer is having on the Black community and what can be done about it is Dr. Karen Winkfield. Dr. Winkfield is an oncologist and the director of the Office of Cancer Health Equity at Wake Forest Comprehensive Cancer Center. She is also one of the featured speakers here at the Healthy Churches 2020 conference. Dr. Winkfield, welcome to the show.
Thank you so much.
Tell us about clinical trials and help our audience understand what a clinical trial is.
So clinical trials are important parts of cancer research, and cancer research can expand through many different phases, including basic science where folks are in the lab and trying to identify mechanisms and how drugs work. But a clinical trial, particularly when it deals with human subjects, is about trying to identify best treatments. Oftentimes we go through treatments for high blood pressure, diabetes. We're always looking for ways to improve care or even to cure some of these ailments. And the best way to identify treatments that can work and work better are through clinical trials. And usually what happens is an individual is enrolled to participate in one of these studies that is testing something that's new. And they are asked to sign consent. And the consent form is an important part of a clinical trial because we want to make sure individuals understand the risks and benefits and can really understand that the drug may or may not work. What's important to remember about cancer clinical trials is no one ever will be placed on a placebo. That's an important distinction between cancer.
No sugar pills.
No sugar pills versus another type of a disorder, maybe high blood pressure, diabetes, where there may be that question of whether or not there may be a sugar pill. But if someone has cancer, we must treat them. And so that's a difference between a cancer clinical trial and some of the other clinical trials that we see that are in medicine. And so from my perspective, cancer clinical trials oftentimes are the best way for individuals to get access to new drugs that potentially can be curative. And it may also be a way for individuals who have gone through the standard of care and may not be responding anymore to really have access to something that may dramatically improve their outcomes.
So what are you seeing as some of the barriers to actually improving the numbers of African Americans that participate in clinical trials? Now, we know the traditional stories out there, but you as a person who's done this for a while, what do you see as some of the barriers that really prevent the numbers from moving in the right direction?
I think it's important to remember that clinical trial participation in general is relatively low. Only about 6% of Americans participate in clinical trials overall, regardless of race or ethnicity. And that's for even things like cancer, where you'd think that the enrollment might be higher for individuals. So overall, clinical trial participation is low, but it's even lower for minority populations and African Americans in particular. And yes, there's history behind that. But one of the challenges that I see all the time as a barrier is lack of information. And so oftentimes patients may not even be aware or know enough to ask whether or not a clinical trial would be best for them. And so part of what we need to do as a community is start to educate individuals about this particular difference in clinical trials related to cancer, the importance that they have, the importance of realizing that Blacks are dying of cancer at a much higher rate. So we have a duty to try to figure out whether or not the treatments that are currently available work as well in our communities as they may for others. We found some very interesting things doing studies, for instance, in high blood pressure, that there are certain medications that work better in African Americans than they do in other populations.
We probably have a list of medications we probably never should have used in African Americans.
Exactly, and so with cancer, we don't have that information because we have such low clinical trial participation. So lack of information is one. I must say, though, that comorbidities can be a challenge as well. So we know that obesity, diabetes, high blood pressure, cardiovascular disease also plague African Americans at a much higher rate. So unfortunately, I feel that many of the clinical trials are set up so if people do have multiple comorbidities, they get excluded. And that can be frustrating for those who do know
True.
And want to participate, and then they're told no, that they can't.
Have screenings helped us improve the knowledge base that the average patient has, and how does that lead to, do you think it can lead to better participation in clinical trials?
I'm not sure that screening in and of itself will help to improve clinical trial participation, but I do believe that education around the importance of screening can be an opportunity to talk about the importance of clinical trials.
Use it as a bridge, so
Exactly, exactly, because we still have work to do around screening, particularly for colorectal cancer screening, which we have very low screening rates for colorectal cancer, even though it's one of our top killers in the Black population. We have the highest incidence of colorectal cancer, and yet only about 30% of the population is getting screened for colorectal cancer. And so we really have to start improving the education around the importance of screening, the fact that screening can save lives. We're talking about colorectal cancer, and in fact, the screening, the colonoscopy, can be preventative. If a polyp is found during the time of the colonoscopy, you remove that polyp, you just save somebody's life, right? So we know that in colon cancer, there's a clear progression from polyp to development of cancer. So we've got to educate our population about the importance of screening and really use it as a bridge to talk about the different treatments that are available. Cancer's not a death sentence. We can treat it. And in many cancers, if it's caught early enough, we can cure it. And clinical trials are there just as a treatment option.
Let's shift pews in this church for a second here. Breast cancer in African American women, it seems that there's been a shift in the numbers. African American women seem to be catching up with the rest of the population. Give us some insight on that.
Yeah. It's interesting because I have a slide in the talk that I gave today that actually shows the incidence, the new cases of breast cancer between race and ethnicity, and has Black women, you know, and white women. What I used to say about that slide is that white women had the highest incidence of breast cancer. That's not so anymore. A study came out, published in December of 2015, that said that Black women now have the same incidence rate as white women. Now, part of that, I think, that increase is related to the fact that we're doing better screening, right? So we saw the same phenomenon in white women, where we really started doing breast cancer screening in the 1980s. And there was certainly an increase, a rise in the number of new cases that were found. But it makes sense. If before what we were doing was relying on physical exam, or if a lump was found, then going and getting checked out, then of course, if you move to screening where you're finding things at a much smaller size, or when they're a ductal carcinoma in situ and non-invasive cancer, you're going to see more of that during the screening process. So right now, I think that upswing that we're seeing in the African American population is just related to improvements in screening. The challenge that I have on that same slide, it also looked at mortality. Even though white women had a higher incidence of breast cancer, Black women were dying of it more. So my concern is that even though we're finding cancers, and we're finding more cancers in Black women, that gap in terms of the outcomes may start to increase. So again, using this as an opportunity to encourage women, it's not just about the screening, it's about follow through. You got to get screened, but then if something's found, you got to follow through. And follow through means understanding the treatment options that are available to you, making sure that you have someone there with you when you're being talked to about the treatments for cancer so that you can have somebody to advocate on your behalf. And sometimes the best way to treat a cancer may be enrollment in a clinical trial, but that's not always the case.
So the first rung on the ladder was screening. But you don't want to stay there. You want to move up the ladder.
Yes.
And what do we do about the findings of screening in any disease state, in particular breast cancer in women?
Exactly.
Are we moving the needle as far as cancer in African Americans are concerned? You know, we've studied these things forever now. We got a zillion research papers. Are we beginning to make progress in this overall picture?
Yeah. So there was a slide that I showed today that clearly outlines that we've made vast improvements in terms of cancer outcomes. If you look at mortality across the board, regardless of race or ethnicity or gender, the mortality rates, the death rates of cancers is declining for everyone. So yes, we're making progress, but there's still that gap. When we look at Black men, they have the highest death rate from cancer than any other race, ethnicity, gender, and it's a big gap. And so we've got to work on prostate cancer in Black men, because that's really where a lot of that highest mortality rate is coming from. We've got to work on lung cancer. A lot of times we don't like to talk about it in the churches, but smoking cessation is really vital. We've got to stop smoking because we're dying of lung cancer, and we're dying of lung cancer at very, very high rates. And people might not be aware that there are screenings now that are available. There's low-dose CT scans or computed tomography that can actually screen and find these lesions. Early detection is key. Early detection saves lives.
Almost in any disease state. We're here at Healthy Churches 2020, and your mission as an ambassador to churches to actually get this message out. What role can the church play for our community in understanding cancer and all the ramifications behind it?
My goal is to empower communities And what better way than through the churches? The Black family, Black community loves their churches. And there's actually a study that suggests that about 80% of Blacks say that faith is important to them.
They identify, don't they?
They do.
Yes.
So what better way to spread a message about health, well-being, importance of prevention of cancers are key, screening, and treatment than through the churches. And my goal is not just to personally be an ambassador, but to empower individuals within the community to then become ambassadors themselves. Talk to your families, talk to your friends, talk to whomever, your congregations, and get out there and spread the word about the importance of these, of cancer, cancer prevention, and cancer care.
A sermon of a different sort.
Yes.
Very good. Thank you so much. We've been here with Dr. Karen Winkfield, Director of the Office of Cancer Health Equity at Wake Forest University. Dr. Winkfield, it's been a pleasure having you on the show. We'll do this again.
Thank you so much.
Thank you for joining us on Primary Care. I'm Dr. Lonnie Joe. For more information about the show and our guests, visit our website at primarycare-tv.com and continue the conversation on Facebook and Twitter.